All right, so, we're gonna talk about head injury. And that is the official definition. Any trauma to the scalp, the skull, or the brain. So clearly, if we're talking about those three things, we're going to have varying degrees of severity, right? If you have a scalp laceration, it's not gonna be as serious as if you have a brain laceration. And you can have brain lacerations where the brain tissue is actually torn and shredded. So there's a wide variation of head injury. Head trauma includes any alteration in consciousness, no matter how brief. What do we know about scalps? Anything besides the fact that it's on our head?
It has layers.
There's different layers. I couldn't hear you in the back.
I said it's a tendency to bleed a lot more.
Tendency to bleed a lot more. There are a ton of blood vessels. So even when we talk about burns, we're gonna talk about how the face swells, it's because of the blood vessels. So when someone has any kind of injury to the scalp or the skull, we have to really take the time to stop the bleeding and actually assess it. So that we're not like making a mountain out of a molehill, or we're not ignoring something that's important. Same child. Before the concussion, when she was much younger, she was 4, I had slate steps in the front of my house. And she was maybe about 3 actually. And she was going up the steps, and she tripped, and she whacked her head on the corner of the slate. And I heard screaming from her and my husband. And I don't have a big house, and the time it took me to get from my kitchen to my front door, which is I'm very bad at dimensions, it's very short. I opened the front door. He is white as a ghost. She is screaming bloody murder, and she is, I'm talking, covered in blood. The top of her little short outfit, she was drenched in blood. She was crying so hard, she was sucking it into her mouth. She was just, I said to my husband, you sit on the step and put your head between your knees because I can't pick you up, you're too big. And I scooped her up, I brought her in the kitchen, I threw her head underneath the sink so that I could see what was bleeding, because it really looked like she had sliced her entire head open. When I finally got all the blood off and I could see, I'm not kidding you, it was maybe half an inch. Half an inch, that's all, but it was deep enough. She did need 8 sutures. But the amount of blood, you would have thought her entire head had been scalped, like right off, with the amount of blood that and I always knew, oh, heads bleed, well, they really bleed. Same child, a few years later. Also before the concussion, fell on a different set of stairs, this time the back of her head. And my mother, that was when my leg was broken. My mother had to take her to the doctor, and my mother was also a nurse, and a very good one, I might add. And they had just come out with Dermabond, and she said, so they were gonna Dermabond it instead of suturing this one. This was in the back of her head. She had fallen backwards. And my mother said to the physician, don't you need to cut her hair so you don't glue it to the wound? And the physician said to her, no, that's the beauty of this. We don't have to shave anymore. So my daughter came home with her hair glued into her wound, which then became infected. So I had to pull the hair out of the wound, reopen the wound, and then I had to take her to a new pediatrician because I wasn't going back to that nut. Well, not me, my mother, because I was still casted and not walking yet. So we can Dermabond scalps, we can suture scalps if they're not too deep. Anyone know how you tell if you need sutures? if you can fit a grain of rice in, I was told this by an ER nurse. If you could put a grain of rice in the wound, and it's not like coming out of the skin, like it's really in the wound, then you need sutures. That's how deep it needs to be. Not standing up, not that kind of rice. Laying down, rice, 1 grain. So, we can do a lot of things to scalps and skulls. Skulls, if they're broken, generally have to heal on their own. Sometimes if depending on what kind of fracture, they might have to take the bone fragments out. They might need to put a plate, but we'll talk about that in a minute. And then the alteration in consciousness. Generally speaking, when there's an alteration in consciousness, we usually call it a concussion, if there's some altered consciousness. When my daughter had a concussion, I told you they didn't want to do a CAT scan because she didn't go out right away, but she went out after she got off the field. She got whacked, she walked off the field, got to the team, and then went boop, right out. And my husband called me and he said, because he did the early games. I already told you, I don't like the morning. So he did early games, I did late games. So the phone is now ringing at like, I don't know, 8 o'clock in the morning. I thought, oh, this can't be good. And he says to me, don't get upset. Very bad way to start a conversation. And in the background, I hear, woo, woo, woo. And I said to him, is that ambulance for her? He said, yes. I said, I will be there before you. And I was dressed in my car. I beat the ambulance to the emergency room. So she went boop after, but she did lose consciousness. And she has to this day, has zero memory of the event. She remembers being out on the field. She remembers the whistle being blown, and that's the last thing she remembers. And she has very little recollection. She really has long-term memory loss of that entire semester. She doesn't remember a lot of things. So, I don't necessarily like having all this experience with this stuff, but anyway. These are the primary causes in the United States. Believe it or not, firearms is #1. Firearm accidents, okay, we're not talking about purposeful shooting somebody in the head. We're talking about firearm accidents are the #1 cause of head injury in this country, which is, to me, very, very frightening. And it's probably something, as you people have children, mine are too grown to worry about it now. You should probably ask, because more people have guns than you think. It's very scary, to me. I find it very scary. So I think now, if I had children now, before I let them go to somebody's house, I would ask them if they had guns. I mean that. I think that's how significant, because there were people that I found out that had guns and I had no idea. I never, ever, ever would have thought they had guns, ever. And my children were in their house. And who knows, right? What do kids think, oh, look at my father's gun? Yeah, not a good idea. Motor vehicle accidents, #2. That has gone down, but it's still #2. But it's gone down since the seatbelt law. Falls, assaults, sports-related injuries, and recreational accidents. So, sports-related are different than recreational, because in sports-related injuries, they are including professional sports, and we do know that there's the whole problem with football players with concussive syndrome, post multiple concussions, where they've had, I think it's the University of Michigan, and I think there's a university in someplace in Canada that actually collects the brains of football players to evaluate them for CTE, which is, I forget what it is, whatever it is. So, and then recreational activity. there is often, a high potential for poor outcomes. And those poor outcomes can be long-term, we're talking about long-term poor outcomes. And if somebody is going to die from a head injury, these are the most common times that we have to watch for death, or watch for impending death. It would be immediately after the injury. Those are those people that, go on a ski trip and have a skiing injury and they hit a tree without a helmet and they're dead instantly. So, immediately after the injury. Within 2 hours after the injury, so they seem fine, everything is going along, everything is lovely, and then they're dead. And the person that I usually use as an example for that is, what is her name? She was an actress. She was, yes, Natasha Richardson. Natasha Richardson. She was in The Parent Trap. She was the mother. She's married to Liam Neeson. That's all I know. Not a big movie person, but she was skiing, and she had an accident, and she said she was fine, and she did not want to go to the hospital to be evaluated. She went back to her hotel room, and then they continued skiing, and then they went back to the hotel room, and she was dead. They airlifted her because she was Natasha Richardson. I think for a regular person, she was already dead, they would not have airlifted her. But it happened after the event, so they seem fine, and then they're dead. And then again, bless you, at 3 weeks after the injury. Because that's usually when people are feeling better, they increase their activity, the intracranial pressure starts to go up again, because they don't follow instructions necessarily, and they're feeling well, and they think, oh, this is better, and then they die. Because the intracranial pressure goes up, and they herniate. So those are the 3 most common points. So we already talked about scalp lacerations. We heard about the daughter. It is the most minor type of head trauma. The scalp is highly vascular, leading to profuse bleeding. You can always have the vision of my daughter being covered in blood. And the major complication is infection, which she also had with the second one because they put her hair in her wound. Yuck. When I think of that. Anyway, so this is probably the simplest head injury you can think about. And really, unless you work in an ER or a doctor's office, you're probably not going to see too many of those. Then we have skull fractures. Skull fractures involve the bones of the skull. So we're talking about the head itself being fractured. There are different types of fractures. So there is a linear, which is actually the most common. Linear means it's like a line. You have a fracture, you fell, you hit your head on the ground, and you get like a fracture line. Depressed is a little bit different. Depressed is when, if you think about what I said earlier, like being hit with a baseball bat or falling with your head on a rock, where the implement that is hitting your head makes a dent, it crushes it. And so what often happens with depressed fractures is you get little tiny fragments of bone in the brain, because when it fractures it toward the center, and more of the pressure is toward the center of the fracture, and then it kind of comes out like a starburst. Okay? So depressed fractures. They can either be simple, comminuted, or compound. Simple is the fracture is not through the skin. Comminuted means it's out of alignment. It's not nice and in alignment. And compound is when the bone is exposed through the skin. So on the head, that would mean that the scalp would have to be torn off. or if they had a depression and one of the corners kind of came out through the skin. If you're thinking about an arm, which you'll talk about in ortho, an arm that's a compound fracture comes through, literally through the skin. So it's pointing in the opposite direction. Skull fractures can be closed or open, and that depends on the skin. If the skin is broken and open, it's an open fracture. If it's closed, then the skin remains intact, but the bone underneath it is fractured. And with everything with the brain, location of the fracture alters the presentation of what we see, of the manifestations of that fracture. So if the fracture is at the base of the skull in the back here, right, you're going to have different symptoms than if the fracture is here. So I can't tell you what the symptoms are gonna be because it's gonna be based on where the injury is. There are some that are more common than others that we will go through, but for the most part, you've just kind of gotta have really good observation and assessment skills. The type and the severity of the skull fracture will depend on the velocity, meaning the speed at which whatever is hitting the head or the head hits something that the person is going at. So if you have a skull fracture from a car accident and the car was going 20 miles an hour, it's gonna be very different than if you have a skull fracture at 80 miles an hour. The momentum, what direction is it going in? What direction is the head going in? And what direction is the object that it is hitting or hitting it going? Then the direction of the, yeah, that's what I just said, of the injuring agent. And then the site of impact. Again, where on the head is it? The momentum has to do with the force in the direction that it's going. So these are the more common skull fractures. Let's just go through them one by one. Clinical manifestations of frontal fractures, so frontal is here, right, your forehead primarily. You're going to get CSF rhinorrhea. What does that mean? You're going to have cerebral spinal fluid coming out of your nose instead of snot. Or mucus, whichever you prefer. I need to sit down. The patient may develop a pneumocranium. What does that say to you?
Air in the skull.
Air, either in the skull or in the tissue, and it feels like, do you remember when you did level 1? And they described crepitus in the lungs, where it feels like bubbles? That's what it feels like on the forehead. As you move your fingers and you assess over the forehead, it's like when you pop the bubble, what are those things? Like the crate, when they pack crates and you get those little poppy things, that's what the head feels like. And so that's air in the forehead tissue. Pneumocranium is the same thing. That's a bad slide, I should try to change that. With an orbital fracture, orbit is when the eye socket itself is broken. So it could be here, it could be here, it could be the top of the cheekbone, but the orbital area. The primary sign and symptom of that is periorbital ecchymosis. And they're also called raccoon eyes. Basically, your eyes get black and blue. Could be something. The other thing that's on this slide, two things, are actually for other fractures, but this right here, this is a special paper, and when you have something dripping from the nose or the ear, if you put that paper underneath it and collect a little, it makes that halo. So red blood cells go to the middle, and then the outer ring, I know it looks green up there, but it's more like a yellow straw color. That is a sign that the liquid that you are getting on that paper is cerebrospinal fluid. Mucus will not do that. Orbital fractures can be very, very dangerous because you can lose the eye, or you can lose the sight in the eye if you keep the eye. Temporal fractures, temporal side of the head, so the side. You get a boggy temporal muscle. Your temporal muscle is right here. It holds your jaw to your head. And what happens is when you get a fracture on the temporal area, because the bone is loose, this muscle gets soft and mushy and boggy because there's nothing holding it in place. There is CSF otorrhea this time, coming out of your ear instead of out of your nose. You can develop an oval-shaped bruise. That's what they're trying to show here. An oval-shaped bruise in the mastoid region. And that's from blood from the fracture going down and settling to the mastoid area. And it looks like a black and blue. There's a picture of it next. It's also called battle sign. The oval-shaped bruise is the battle sign. See here? That's what it is. That's what it looks like. The parietal area of the skull is the main part of the skull, here, right? Behind the frontal, right here. So there are all kinds of structures there. Deafness, because the cranial nerve that is responsible for hearing is there. There can be cerebral spinal fluid or brain otorrhea, meaning you can have pieces of brain coming through the eardrum. If the brain is crushed and the skull is broken, in addition to cerebral spinal fluid coming out of the ear, we can have brain tissue also. There can be bulging of the tympanic membrane when you look with an otoscope, and instead of the membrane being nice and flat, it's bulging because there's pressure from behind it. There can be facial paralysis because, again, the cranial nerve that's involved with facial expression is in the parietal area. There can be a loss of taste because of the cranial nerve. And you can also get a battle sign. Just like we did with the temporal, you can get one with the parietal. Because it's the fluid, the blood moves down and settles in the lowest area. The posterior fossa is the back part of the head, and occipital bruising can result in blindness because we know this part back here, the occipital, is where most of our vision is. There could be visual field defects. Even if the patient can see, they may lose certain fields of vision. And they may have ataxia or other cerebellar signs, although those are rare. They can happen. Basilar skull fractures are a little bit lower than the occipital. You can once again have CSF or brain otorrhea. You can also have tympanic membranes bulging, battle signs. You can have difficulty with hearing with this one and or tinnitus. What's tinnitus? Ringing, a constant ringing in your ear. There can be facial paralysis. There can be conjugate deviation of gaze, meaning the eyes go in two different directions. There may be vertigo. And one thing that's missing up there is with basilar skull fractures, there's a higher risk of infection because there can be with that, well, actually, any place where there's CSF coming out of the brain or the nose, there's a much higher risk of infection because there is a communication directly from the outside in. So any little organism that goes up your nose, if you've got cerebral spinal fluid coming out, runs the possibility of getting into your brain area. So the test, which I already pointed you to, CSF, you can either test it with a dextro stick. In the olden days, before we did finger sticks, we actually tested people's sugar by using a dextrose stick. It's a little stick. It comes in the same canisters as the finger stick strips. And they have little pads on them that are different colors. And you would dip it in the urine, and depending on how high the sugar was in the urine, those little pads would turn colors. And you would get a range of of sugar in the urine, and that would give you an idea of what the blood sugar was. But you can also use a dextrose stick to look for the glucose, because CSF has glucose in it, whereas mucus does not. So that's one way of differentiating. That second way is to allow the cerebral spinal fluid, or whatever fluid it is, to drip on that little white pad that I told you about, and then you look for the halo or the ring, with the red cells in the middle and the straw color on the outside. So there are two ways to check to see if the fluid's cerebral spinal fluid or not. I'm losing steam. There are different ways of classifying head injuries. We already talked about open or closed. There's also minor and major. So in minor brain trauma, also known as a concussion, you have a mechanical head injury, meaning something has hit the head or the head has hit something. And there's a disruption of metabolic activity in the brain, which is the neural activity, and also a change in their level of consciousness. The change in level of consciousness can be brief, or it could be a little bit longer than brief, like a couple of minutes. If it lasts longer than a couple of minutes, it's probably a much more serious concussion than a minor concussion. Your book doesn't really go into it, but concussions are graded from a 1 to 4, with 4 being the worst and 1 being the least. So a lot of what's up here is about a grade 1. When you get higher, the symptoms become more severe. There is amnesia of the event, which we already talked about. There is headache, which we also already talked about. And it generally is a short duration. Again, based on the grade of the concussion, that duration can be anywhere from a couple of weeks to a year to 2 years for the effects to still be working themselves out. If it goes into the 2-week, 2-month, 4-week, whatever time frame, they often call it post-concussive syndrome, where the patient now has a secondary diagnosis. They've had a concussion, and now they have post-concussive syndrome. This is when they have persistent symptoms, the most common ones being persistent headache, lethargy, personality, and behavior changes. In a major head trauma, there are a couple of different kinds. The first one being a contusion. The contusion is the bruising of brain tissue, so there would be a little bit of a bleed, it would look like a hematoma. And it's only in a focal area, it's not a gigantic area of the brain. But the pia mater and the arachnoid layers stay intact. So it hasn't really disrupted the actual brain tissue. So it's kind of like, think about it like a black and blue on your brain. That's kind of what it is. Lacerations are actually the tearing of brain tissue. So when you have a tear in your brain tissue, it means that there have been different forces acting on the brain, pushing it and pulling it in different directions. Or it could have been caused by a fracture that had fragments that went into the brain and tore it that way. There is often hemorrhage associated with a cerebral laceration, so you have a contusion plus a laceration. Can anyone think of anything that you've learned about or heard about in popular news that would indicate like a brain laceration? Unfortunately, we hear it more and more. Babies with shaken baby syndrome, when they do this with anger with a child and their head is whipping back and forth, their brains are so little in their big skulls because they haven't grown yet, right? What do we know about babies? They have these gigantic skulls and they have these little brains that have to grow into them. When they shake them like that, the head, the brain goes in, within the skull, the brain goes back and forth. And with that brain moving back and forth in the opposite direction of the skull, so when the skull goes this way, the momentum pushes the brain back. And when the brain goes this way, the brain falls forward. So you're going back and forth, and it actually tears their little brains, and then they die. We used to see that in whiplash, when you had whiplash injuries in a car accident, because before we had shoulder belts, first there were no seat belts. We would all just pile in the car, sit in the car, really close, all kinds of people. Then we had lap belts. Only the lap. So if you were in a car accident, you bent forward, you hit your head. You broke your back because you were like that. Then they went to shoulder straps. Now we don't have this, like this, the head injury that we would see. It's called whiplash, where your head, and you bang it. But that is where you get lacerations in your brain. That's one of the ways. So we do often see this with children. They often do not survive when the shaking has been severe enough to do that kind of damage to the brain. And that should be skull fractures, not skill. So lacerations can also occur with skull fractures, as I said earlier. If there's a piece of bone jutting into the brain, it can lacerate it. So, but the most common are the shaken baby, and that's actually called a coup, contra coup injury. It's French, C-O-U-P, contra, C-O-N-T-R-A, coup, C-O-U-P, coup, contra coup injury. And it can even happen to adults. When my daughter had the concussion, she was hit on the right side of her head, in her right temple. Her contusion was left occipital. Because when she got hit, her brain got pushed this way. because of the force of that, because she got hit with a ball. When the ball came at her, the ball hit her here, and her brain inside her skull whipped to the back. So she had nothing here. She didn't even have a black and blue. If my husband had not witnessed it, we would not have known where she got hit until they did the CAT scan. And the CAT scan was left occipital bruising. And that's where the swelling was, and that's where the little bit of the herniation was happening. It was all happening back here. And a lot of her symptoms were visual, right? I told you, she couldn't do this, she couldn't do the lights, all those things. So it all kind of fits together. But lacerations are not good in the brain. A diffuse axonal injury, or a DIA, is when there is widespread damage due to a traumatic brain injury. TBI is traumatic brain injury. So this is what we would see with like maybe a class 4 concussion even. You would see this diffuse axonal injury. It takes about 12 to 24 hours for it to completely mature, the injury itself to mature. And the damage around the axon, in the white matter, in the basal ganglia, in the brainstem, it's widespread. The clinical signs are decreased level of consciousness, increased intracranial pressure, that decortication and decerebration, which I spoke about, which I said I will explain tomorrow, and global cerebral edema, so the entire brain swells. This is a major, major injury. It's going to take a very long time for the patient to recover if they do. And even if they recover, they may not recover to exactly what they were before the injury. So some other things that can happen with head injury can either be additional complications, or they can be independent events. Some patients with, as we get older and our blood vessels are a little more fragile, they may develop one of these, even with a very small injury. Other people may develop them because they've had a traumatic brain injury. So an epidural hematoma is bleeding that occurs between the dura mater and the inner surfaces of the skull. This is a neurological emergency because the patient will die. And even though it says they're venous or arterial, the reason that most people will die from this is because they are most often arterial. And what do we know about arteries? Pressure, and they keep on pumping, right? Unlike a vein with those pressure receptors, that they will eventually, if there's not enough fluid to fill them, they eventually close off and tamp themselves off. Arteries don't do that. Arteries will continue to pump until there's not an ounce of blood left. So, they are more frequently arterial than venous, and that is why they are so dangerous. Subdural hematoma is actually not as dangerous. They are sometimes called chronic, and unless, I'm sorry, I forgot to explain what a burr hole is. A burr hole is literally a hole in your head. When you do neurosurgery or orthopedic surgery, and we're working on bones, it looks like the machinery comes from your garage. They literally have like drills, different drill bits. They have saws, they have different shaped saws and all kinds of fun stuff like that. So when they are diagnosed with epidural hematoma, which the only way you can do that is either with a CT or an MRI, then they will make the decision to put burr holes in, and they literally take a drill that you buy in like Home Depot, hopefully it's sterilized, and they put holes in the head near where the hematoma is. so that it can drain. And so there can be some swelling that, we'll talk about that in a minute. So that's what a burr hole is. It allows them to put in a drain and for it to be drained, and then they can also go in if they can find where the tear is and sew it up. Because I said, if it's arterial, it's gonna just keep pumping until they fix it. Subdural hematoma is almost always venous. They are much slower to develop. They are much slower to produce symptoms because they're much slower to develop. And they almost exclusively occur between the dura mater and the arachnoid layer of the meningeal covering of the brain. So it's there's a little more cushioning there for the brain. Again, could be arterial, but very unlikely. And because they're slower, sometimes they just let them be. They'll just let them, they happen, patient gets symptoms, they'll do a CAT scan, they'll see it, and they'll say, okay, we'll watch it, we'll do another one in 3 months, and see if it gets reabsorbed. If, however, it's causing gigantic problems and the patient is very symptomatic because they waited for like ever and now it's gigantic and taking up half the brain, they will do the burr holes for these as well. But it's more likely that the intracranial pressure is not that high, they're not that symptomatic, and they just let them reabsorb like we would let a black and blue work its way through itself. So it's the same thing. Simple. And here would be pictures. So the one on the bottom left is the epidural hematoma. That is the one that is the emergency one. As you can see, it is squishing the brain. It is uncal, right, because it's coming from the lateral side. And you can see in these pictures what happens when the brain gets pushed. The ventricles get squished, everything gets pushed over. So you can imagine that if this happened here, you'd have different symptoms. Sometimes a picture is worth 1,000 words. On the subdural hematoma side, it's also squished, but not as much. It's not including the meninges, it's directly under the meninges. And it's going to reabsorb at a slow pace, but it's going to reabsorb on its own. The other one will not do that. So some of the complications that occur with these two events. In acute subdural hematoma, generally within 48 hours of the injury, you're going to have symptoms. The symptoms are going to depend on where it is. The patient can appear drowsy and confused. They can have a headache. The ipsilateral pupil is dilated and eventually will become fixed. In a subacute subdural hematoma, that's in like the 2 week, the second day to the 14th day of the injury, if they're waiting for it to absorb. And they can not wake up if they're already in a coma. They cannot regain consciousness, and this can be an indication that the subdural hematoma is lasting longer than they anticipated. And then a chronic hematoma develops over weeks or months after what someone thought was a minor head injury. So, and people live with them. They very rarely go in and drain them or do anything about them. They may put them on a little bit of a fluid restriction to help just kind of decrease the rest of the fluid that's in the brain and not cause as many symptoms. But those are some of the complications with a subdural hematoma. diagnostic studies. CT scan is considered best overall. When we have a head trauma, MRI would be next if they wanted to look at some other soft tissues. Are you all familiar with PET scans? A PET scan is a positron emission something. Yeah, it's not coming to me. But what it, see, I always tell you when I don't know. What it is it's a scan that looks at the metabolism that's going on in your body. And when more metabolism is going on, it usually means one of two things. It means there's an injury and the body is attempting to heal it, or it means there's something there that's using all the glucose up in that area. This is what you see when you watch TV and they show those scans that are orange and green and red and blue, and they're all pretty colors. All the colors are indicative of the amount of metabolism going on in that area. They'll use it to check to see how these are progressing or regressing. They'll use PET scans to look at oncology patients to see if there's any tumor activity, because tumor activity has a higher metabolism. So they'll use that as a guide. It is not really diagnostic for a specific disease, but it will tell you the state of the disease is in, okay? Cervical spine x-rays, also important when you have a head injury, because you have to make sure you haven't injured the higher cervical vertebra, which are really kind of almost up in the brain, in the foramen magnum. And once again, the Glasgow-Coma scale that you haven't looked at yet. Some procedures that are done. I don't know if they do the suffixes anymore in level 1? Like otomy, plasty, ectomy, no? Okay, they do?
I remember, right.
Okay, so craniotomy means that there's going to be a hole in the head. That means, craniotomy means they're going to be making some type of incision and opening the head. A craniectomy, ectomy means removal of. Like appendectomy, you remove the appendix, right? Cranioplasty means they're going to be fixing the structure, like plastic surgery. So rhinoplasty is when you fix your nose. Cranioplasty is when they fix the head. So if there's been a depression fracture, or there's been, I don't know, something else that causes a defect in, or if they've had to remove part of the head, the skull, which we'll talk about in 1 minute, then they might need to put a plate. It can either be a titanium plate or a plastic plate or whatever. And then there's the burr holes, which I already explained. Now, when we talk about cranioplasty, one of the things that they're doing more frequently now that actually started with the first Gulf War, because in the first Gulf War, it was the first time there had been the IEDs that were literally blowing people to smithereens. And what they were finding was that a lot of the men and women that were fighting had head injuries. So what they started to do, because they figured, and the article that I read actually says this, that they really thought that they were at such risk for dying, they would do anything, even if they didn't know it was gonna work. So what they did was they would take off a large part of the skull, surgically remove it, like cut the bone, and remove the skull. And what that would actually do, that would allow the brain to swell, to get that increased intracranial pressure, get that as cerebral edema, but now there's no skull for it to hit against. So they felt that perhaps they would have a better chance at survival because they weren't dying from the increased intracranial pressure. They would take, if the bone was intact, they would take the bone and they would put it in a pocket in their abdomen because it would be fed with blood vessels and it would stay alive. If it was not, they would throw it away, and then they would use a plate or they would use a bone graft. And they would allow the brain to get to maximum swelling, which usually takes about 3 to 4 days. It would have to be clearly, strictly asepsis, right? Right? We want to have surgical asepsis in this kind of situation because we do not want to introduce anything into that brain as it's expanding outside of its skull. And they would have it wrapped in sterile stuff, and they would have antibiotics, and then when the brain went back, the patient would be fitted with a plate. And they would reconstruct the head, or they would put the bone back if they saved it, or if they were using bone from a bone bank, they would fit it to fit into the patient. So, and they have had they started having significant positive results because the patients were not dying of cerebral edema and increased intracranial pressure. And there is a famous newspaper reporter from Channel 7, Bob Woodruff, I think that's his name, who was blown up in a Humvee when they had the reporters in with the people, the army people. And he was in a Humvee. The Humvee hit an IED, he was blown up, his head was exploded, he had shrapnel in his brain, and he now reports again. And he and his wife, you could probably find it on YouTube, did a documentary from when he was in Germany where they did the original surgery and removed the skull. They have all his CAT scans. You can see what the skull looks like without the piece missing with his brain swollen. And they show how long it took for him to relearn things. Like his kids would sit with him at dinner with flashcards and pictures. And like, okay, this is a fork. And he'd look at it, and he'd say fork. And then they'd do 2 more cards, and they'd go back to the fork, and he'd say, yeah, I don't know. Like, and he had to learn how to walk, and he learned how to, and now he's reporting again. He's been reporting now for a number of years. So if anyone has an interest in it, he's out there, if you want to watch it. So all of those things actually fit to what they did with him. They did a craniectomy, they also did cranioplasty, and they started with burrs. So he had the whole gamut. So, some complications with any type of head injury: decreased perfusion, cerebral edema and herniation we've talked about, impaired oxygen and ventilation, that will depend on if the brainstem is involved or if there's swelling around it, impaired fluid and electrolyte nutrition and balance, post-traumatic seizures, and then systemic infections. And what's in white is what some of the interventions are for each of those things. So CPP is cerebral pulse pressure, I think. And we want it to be greater than 70 millimeters. Again, you can't really measure that. But you're gonna know if your patient is not perfusing their brain by their behavior, and by their language, and by their level of consciousness, and all of those things. If you're measuring ICP between 10 and 20, we said 15, so it's about the same thing. Mechanical ventilation and ABGs to monitor and improve their oxygenation. Impaired fluid, electrolyte, and nutrition. They may have parenteral nutrition. They may also need some insulin if they're not managing their insulin with the all of the cortisol from the stress the physiological stress. We already talked about hypertonic fluids. This also says some potassium. The parenteral nutrition you gotta be careful with, because if the patient has a working gut, you know the rule, if the patient has a working gut, we always give enteral feedings first. If they don't have a working gut, then we would go to parenteral feedings, or if they needed too many calories. If they had lost a lot of weight due to the trauma, and they needed so many extra calories that they would not be able to get enough enterally, then we would do parenteral nutrition. If they have enteral nutrition, what do we need to worry about? I just said the gut had to be working, what else?
Aspiration?
I'm sorry?
Swelling of the abdomen?
You might have distension. What else might you have with enteral feedings? What do we know about enteral feedings? Anything? Enteral feedings have very high osmolarity. So they're very heavy fluids. And because they're heavy, like not physically heavy, but molecularly heavy, they pull water into the gut. And when they pull water into the gut, patients get severe diarrhea. Have you ever had a patient on a tube feed that also had diarrhea? That's the reason. Yeah,
Is that similar to, like dumping syndrome?
similar to dumping. Okay, so all this water is being pulled in, which for this patient may not be a terrible idea because we want to get the fluid out of their brain. And if we get it out of the rest of their system, whatever's in the brain will also come out. But if it's going to cause severe diarrhea and then a loss of nutrition, we're kind of doing one good thing and then one bad thing. So we have to find a happy medium. That's something that you as a nurse have control over to some extent. If the patient has severe diarrhea and they are on enteral feedings, you can cut the enteral feeding with water so that the osmolarity goes down. And it's not quite as heavy and it's not pulling as much water. They're also getting some extra water by you mixing it. That being said, you do need to consult with the physician and the nutritionist to say, now how fast do I have to run this in order for the patient to get the right amount of calories? Because they set the amount of food per hour based on how many calories the patient needs. So if you are now cutting that in half, you're gonna have to maybe double the rate. But it still helps with the diarrhea, because it's not the rate, it's not the amount that's bothering their gut. What's bothering their gut is the heaviness of the feed. So again, something that's in your control. Or at least in your assessment control. So, with a head injury, your assessment's going to include the Glasgow Coma Scale. I promise you'll understand this morning. Vital signs, we're gonna look for that Cushing's triad. You gotta make sure that airway stays open, because if they're not breathing, then none of this works. We're going to be assessing their motor function for return of function or loss of function. Because if for some reason, instead of getting better, the intracranial pressure is getting worse, they will begin to lose more function. So you're looking not just for improvement, you're looking for alterations. You wanna look at psychological functioning. We already said that a bunch of them, this says 60% develop personality changes, not personal, but personality changes. Those personality changes may be permanent. And sometimes that's really hard for families to live with. Fluid and electrolyte balance, you need to keep your eye on what fluids they have going, how it's impacting their electrolytes, what are their electrolytes doing, and who do you need to notify to let them know what's cooking. GI system, you're going to do an assessment, you're going to look for signs and symptoms of bleeding. What are they from the GI system? very obvious one,
Blood and stool.
blood in the stool. What's this less obvious? A rigid abdomen. A hard, rigid abdomen is a sign of internal bleeding. So if you come in the morning and your patient's abdomen is a little distended, a little soft, but not so soft, and when you do an assessment 8 hours later, it's hard as a rock, you need to call somebody, but that's a big change. You also need to listen for a paralytic ileus. As I said, we need to make sure the gut is working before we feed them. If they have a paralytic ileus, their gut is not working, it is paralyzed. And how do we know that? No vowel sounds. And we also want, that should probably say GI-GU systems, because urinary incontinence does not fit with GI. We need to also check for urinary incontinence for a couple of reasons. Is it due to their head injury? Or are they losing, do they have more loss of consciousness than we think they do? We also have to worry that they're gonna break down. But the first two things for a head injury person are more important. Are they incontinent because they don't even know that they need to urinate? Or are they losing even more consciousness than they had? And then for the cardiac system, we're gonna be watching for DVTs, so we're gonna be doing turning and positioning. We're going to be making sure that we are assessing for Hohmann sign. We are going to, if we have the patient on the side, we're gonna put a pillow between their legs so they're not pressing with the pressure on each other. And we're also gonna look for signs of pulmonary embolism. Those are more acute. What are the signs of pulmonary embolism? Shortness of breath that is acute. 1 minute they're talking to you, the next minute they're I'm not having a pulmonary embolism. I probably just inhaled fibers from this stupid mask all day. Okay. I have my mask. So, overall goals, we want to maintain an airway so that we can have adequate cerebral perfusion, because without cerebral perfusion, we have nothing. We want to monitor for seizures and seizure activity. We want to avoid NG tubes if possible. We also want to avoid sneezing, blowing their nose, and suctioning, because all of those things increase the pressure in the abdominal cavity and then go up to the brain. We want to monitor their temperature because we want to make sure that they are not hypo or hyperthermic. Both conditions will cause changes in the brain that are not going to be good for this patient. If they're hyperthermic, we may need to put them on a cooling blanket. Are you familiar with cooling blankets? Okay. You know never to put a patient directly on a cooling blanket. You have to put a sheet in between because it can do damage to the skin. We do want to make sure that they are free from pain, discomfort, and infection. We can't always do anything about infection other than give them their antibiotics. But we do want to make sure that they are free from pain, because what will pain do? Increase the brain metabolism also, because all they're thinking about, all they're feeling is pain. We do have to walk a fine line, because if we're talking about changes of level in consciousness as giving us an indication of what's going on with what's wrong with them, if we give them a narcotic, it's also has the possibility of changing their level of consciousness. So we usually use weak narcotics. So a weak narcotic is codeine. It's still a narcotic, but it's a weak one. We want to do an antiemetic for nausea and vomiting. You see there, it says no opioids. That's debatable. They sometimes, if you've got a patient with a head injury who also has a broken back and 2 broken legs, there may not be an option other than an opioid drug. You just, then your assessment and your careful watching has to be on point all the time. Because you got 2 different things going on. There may be a loss of corneal reflex. If there is a loss of corneal reflex and they're not blinking, then you need to put artificial tears. And then periodically, like once every hour, you need to take paper tape, close their eyelids, and tape them down for about 3 to 5 minutes, so that the eye can just rest. Because if, just think about that. If you had no blink reflex and you were just sitting there with your eyes like this, your whole eye would dry out. And it would, then you would get corneal scratches, and you would get corneal abrasions, and then you'd get infections, and then we have a problem. So some pre-planning and just taking care of things before they happen is sometimes, not sometimes, is always better. You do not want this patient in a room with a patient who screams and yells all night, or has 52,000 visitors, which in the time of COVID, you may not have to worry about. But once COVID passes, and, you know, and I am a huge, don't get me wrong, I am a huge proponent of family being allowed in the room at all times, whenever they wanna be there. But it also has to be with thought if they're in a double room to the second patient. Because we can't put one person's health and wellness above a different person's. So, but in particular, patients with head injuries should be in a place that's quiet, that the lighting can be subdued, that there aren't 4,000 people in the room, and those kinds of things. You want to be doing, all of your interventions are going to be focused on making the functioning of the brain at least as good as it is, if not better, after the traumatic brain injury. And last but not least, we want to always think about the skin. These patients may or may not be able to turn themselves, and believe it or not, people die from pressure ulcers. They die from sepsis from pressure ulcers. And again, I'm not a huge proponent that nurses are always on the line, that this is their fault if it happens. I don't believe that, because I absolutely believe that there are some circumstances that we just can't change. We can't change poor nutrition. We can't change the fact that somebody is 90-year-old and has very poor circulation, and they're laying on their, no matter where you put them, it's a pressure point. I mean, there are some things that are just out of our control, and that we are constantly belittled and I don't know what the word, blamed for. All pressure ulcers is wrong. That being said, we do have a fair amount of control over a patient's skin. So we need to make sure that we do pay attention to it. Because that would be a terrible thing for somebody to drive. In terms of health promotion, remember I said yesterday that on the NCLEX, was it only yesterday? Oh no, it was Tuesday. Oh no, whatever day it was, yeah, Tuesday. That some of the things that we don't do are community health and that kind of stuff. Well, health promotion is one of those things that falls under community, so we don't always do it. But one of the things we could do for head injury in terms of health promotion is to prevent car and motorcycle accidents, to talk about gun control, as I said earlier, since that's number one, to encourage the use of wearing safety helmets. You know, my daughter went to school in New Hampshire, and that's called the live free or die state. Like, they really like their rules that they don't want to follow, and they love that they don't follow them. They are allowed, their speed limit is 85 miles an hour on their main roads, like the interstate. And they do not have to wear helmets on a motorcycle.
Or seatbelts.
What?
No seatbelts.
And no seatbelts. There's no seatbelt laws.
No car insurance.
No
What?
car insurance.
Live free or die. They want no government intervention.
Like you could talk on the phone.
I really, one of these days, I'm gonna look up the incidence of head injuries in New Hampshire. But we can still promote it, even if it's, you know, this is part of our job. Part of our job is learning how to promote what is healthy for people. Whether it's wearing a helmet, gun control, the use of, if you're gonna have a gun, where you're gonna keep it. I mean, that doesn't always sound like nursing, but it really is. It's like when I would get my son and his friends in the car, and the door would be locked, and we'd be going down the parkway at 65 miles an hour, that's when I talked about sex. Because they couldn't jump out of the car, and I felt it was my responsibility to make sure they all knew about it. And my poor son would get red, his ears, his chest, he would say, "Not again." And I'm like, "Nope, again." Because until I know that you know what you're not supposed to do and what you are supposed to do, and if you're gonna do what you're not supposed to do, then what you need to do with it, you will have these discussions. He was like, "This is so embarrassing." Like, I understand that, but I take my job very serious, and you can't ever not be a nurse. Once you're really a nurse, it's like, my kids would say that to me when I was little, when they were little, not when I was little. They would say to me, "Can you just not be a nurse? Can you be a mom?" I'm like, "No, I don't know how to do that. I can be a mom nurse or a nurse mom." They're like, "You're always telling us things." I'm like, "Yes." Too bad. So, for head injury, we have to think about how we are going to inform the public without being preachy. I mean, I was allowed to be preachy, they were my children. But you can't really be preachy to strangers. But you have to figure out a way to educate them in a way that they get the message and maybe they even listen. That would be nice. They don't always. But those are the things that we think about with health. I think about, you know, I went on a giant campaign with the high school after my daughter had her concussion because they cleared her after 2 weeks to play. So she was like ready in her uniform. I'm like, "No." I said, "The doctor said at least 6 weeks, but they cleared me from the health office." Well, health office is not in charge of you. I am. So then I had to go to the health office, and I had to talk to the nurse. And then the nurse said to me, "Well, you know, I printed out like 12 articles, including one that the physician that my daughter was seeing wrote. And I brought them in. And I said to her, please read these before you do anything else with any other child." And they were like, I bothered them for a year and a half. And then a year and a half later, they finally changed their policy. But I had to involve the coaches. My children were not happy with me. I had to involve the, what are those called? The athletic trainers. I had meetings with them. I was not letting this go because I could not believe that she was still symptomatic, and they cleared her. And they cleared her without asking me if they could clear her. They were like, "Well, she came into the office and said, 'Can I play?'" I was like, "She's 14. She's not allowed to make that decision." So part of what we do always is health promotion and health education, and what can we do with the public to make sure they're getting the message without beating them over the head. My children I can beat over the head, they're mine. I can't beat strangers' children. Except when I have them locked in my car, then I can say what I want. Hey, we had no teenage pregnancies. I was very happy. Okay, so ambulatory care and home care, again, something we don't have a whole course in, but once the patient goes home, these are some of the problems that the patient may or may not have. So we're gonna worry about nutrition, because if they don't have proper nutrition, they're going to start using inappropriate fuel sources, and it's going to end up hurting their brain. Again, the bowel and bladder management, because of the increased pressure in the abdominal cavity. They may develop some spasticity if they've been having some motor control problems. And that may require either physical therapy or occupational therapy or medication to go with it. They may have some dysphagia. So we need to worry about whether or not they're swallowing. And if they have to be on a special diet, that goes back to their nutrition. We need to put the family and the patient on alert for the possibility of seizures. And seizures don't always have to be those grand mal things that we all see on TV that are, it's very dramatic. But sometimes seizures are just a disconnect with the world for 40 seconds or 60 seconds. So being alert to that is important, because if we don't catch it, every time they have seizures, they could do more and more brain damage. So putting them on medication as early as possible is important. And then family participation in education. I already said it, I am a huge proponent of families being involved. I think they make the world of difference. I never find them to be a pain in the neck. I know other nurses will be, oh my God, that family is here again. And I am like, oh, thank God they're here. Even if they bother me, which is really not a bother, but even if they ask me 1,000 questions, they can at least sit with the patient, and they can observe the patient, and they know the patient, and they can give me information. I never mind family. It's probably why I do what I do and I don't work in ICU. Because I do like families around. I like that ability that they can be involved, and they're gonna have to take this patient home. So we have to be able to, what's the word I'm looking for? To be able to transmit information in a way that they're gonna be able to manage this patient at home. And that's our job. So how can we do it if they're not there, or if we're always calling them pains in the neck? Oh, thank God they're here again. I'm so happy when a family comes. So happy. They are, and there's most of them, I won't say all, but most of them really wanna help. You give them a job, they're like, you know what? He needs to be turned in an hour. I'll come in and help you, but you come and get me in an hour. Then I don't have to even think about it. Because I know in 1 hour they're gonna come and find me. We can utilize them. They can have, it's their family. They know how to give a bath. I'm reading a book. Anyone read the new book by James Patterson called ER Nurses? I don't usually, my sister-in-law gave it to me for Christmas. I don't usually read James Patterson. And it's not like not a story. It's not a novel. It's a compilation of stories of nurses during the pandemic. And not just during the pandemic, mostly the pandemic, but other times as well. And this one nurse talks about how she was caring for a man who was dying. He was in his 40s. He had 3 small children. He was dying of all things, pancreatic cancer. And she said the wife was beside herself. She didn't know what to do. She came every day. She didn't know what to do. And she finally said to her, would you like to help me wash him? And the wife said to her, I haven't seen him without clothes since he got sick. He hasn't allowed me. And she said, it's okay. She said, I'll do it with you. We'll do it together. And she said, she talks about the care and the tenderness with which the wife was cleaning the husband for the first time and seeing his body. And then she was exhausted, he was exhausted. And she said, the nurse said to the wife, you know, you look tired, why don't you take a nap? And she closed the lights, and he was in a private room, and she said, you can get in bed with him. She said, we haven't slept together in 19 months. She said, I've never been next to this body that's so different. She said, he's still your husband. Get him, and then one of the older nurses reported her. But she said, I don't care. and he was dead that night. Very touching story, but very human. And we have to include patients. And here she had been excluded for all of this time and was afraid of her own husband. And all it took was one little opportunity, really, for both of them. It probably gave him permission to finally die. So even though that's a little different than this, utilizing families and family education and allowing them and encouraging them to participate in somebody's care is vital to who they are. And that's really up to us to do. Okay, so tomorrow, I will see you, oh, we have to make it 9 o'clock again. And tomorrow morning,
빨리 끝날까 기대도 안 했는데.
tomorrow morning, we are in 126 in HP. I don't know where that is. I presume it's on the first floor. Has anybody ever been in that room?
HP?
Okay, well, I'm presuming it's down that hallway on the first floor. It's gotta be there somewhere. So that's where we are.
126 우리 가본 데 아니야?
I will see you there at 9 o'clock tomorrow.
멘탈 하는 거 아니야? 1층 어디 1층?